CommHIT.
I'd like to introduce Dr. David Willis. He's the co-founder of CommHIT. Dr. Willis is a board-certified family physician. He has over 20 years in experience as a private entrepreneur, hospital chief medical information officer, and community health center chief medical officer, or CMO. As CMO of this level 3 certified medical home, he oversaw services spanning pediatric and adult medicine, dental, maternity, and behavioral health care. His dedication to digital healthcare earned him the 2013 Critical Access and Rural Hospital Champion Award from the Assistant Secretary for Technology Policy. He holds a mathematics degree from Stetson, an MD from the University of South Florida, and he completed his family practice residency at Florida Hospital in Orlando. His work continues to transform healthcare, bridging technology and compassion. And Dr. Willis is my favorite business partner, if you didn't know that already. We co-founded CommHIT many, many years ago. So Dr. Willis, please share updates on the Medicare Community Health Services reimbursements and how the reimbursements can then be linked to mobile integrated health program offerings.
All right, thank you, Kendra. Before I start that, the last speaker, when she was talking about ACA, we had a great conversation over there that I think was valuable for everyone if you have an MIH program. The ENS system could apply to you if you have a population of patients that you are managing in your MIH program. You would then be a subscriber to the ENS service. So anytime any one of those patients matches data that's in the ENS system, you would be notified anytime one of those patients was admitted, discharged, or transferred within any hospital system that's participating in the entire state of Florida. So if you want to keep track of those people that you are managing and you're working with, that would be a great way to do it. So definitely talk to the folks down at ACA and see if that would apply to you and your situation. All right, so we're going to talk about reimbursement. So we're landing this rocket back like those of you saw last night. If you didn't see it, then you probably heard the sonic boom. That's what it was. So anyone who follows Medicare knows that what Medicare does, typically Medicaid and other commercial insurers will follow. So we're going to kind of start with this notion that Medicare is what we're interested in, trying to get you all some reimbursement to create a sustainable business model. But then we're going to branch out a little bit to talk about what might be available in both commercial and Medicaid markets as well. These are the learning objectives. We're going to talk about these. We're going to focus on some chronic disease management as a possible reimbursement model, community integrated services, and then how we might set up some of those financial models, and then some of the resources that hopefully we can get you to after this presentation and this meeting. So we can get grants. We're going to talk about some examples that you all have given us about grants that you have worked with in your communities, chronic disease management, integrated health, and then Medicaid services. So many of you have maybe worked with hospitals on frequent flyers to the emergency room, trying to see them after discharge to prevent them from coming back into discharge. Perhaps it's a post-operative monitoring or a congestive heart failure patient that the hospital doesn't want readmitted within 30 days because then they don't get paid for that readmission. And if you could see them for a small cost, you have avoided a very big cost to them. And there are a few of you in the state that are working on programs like that, either have done, we know that's happened somewhat in our County of Marion. I know the Dade County people, they were talking to me about something they're working on right now. So the other thing that we're seeing is some people are using Medicaid, medication-assisted treatment delivery and other opioid-related programs because of all the opioid dollars that came into our state over the last several years, probably longer than that, but it's still an epidemic. It's still a big problem. Those dollars are dwindling at this point, but there still may be opportunity for you to engage and say, help a federally qualified health center who needs to administer a monthly shot. You could go administer that shot and have them pay you to do that. There could be other programs that are related to other delivery systems or managing or monitoring patients on behalf of someone else where you would be the contracted service in your MIH program. Chronic disease management. This is not something that typically I have heard you all talking about, so I wanted to at least mention it as an opportunity. So chronic disease management has been around for a long time, and this kind of set the stage for how things developed. In October of 2023, when we talked about community health integration services, I had mentioned this is what it was built off of. Typically, this is done by a contracted organization, or a large clinic itself may have the people to do it. You find a person who has 2 or more chronic diseases, then you spend 20 minutes via phone, typically, not typically in person, and you're interacting with that patient about their medications, about getting to the right appointments, working with them to make sure that their chronic disease is better managed outside of the traditional office visits. Now, the key here is, and this is going to come up a number of times, it has to be incident to a physician or other clinician. So they initiate saying, hey, look, this person has these chronic illnesses, they need to be better managed. I'm going to get you, this MIH program, this other contracted service, et cetera, to spend at least 20 minutes a month talking to them, and then we can bill for that. So the focus is care coordination, medication management, engaging the patient outside of the traditional office setting, and then Medicare will pay for that. So here are the basic codes that would be used for the first 20 minutes. You can also get paid for additional 20 minutes if you're legitimately spending it, documenting it, et cetera. The complex codes I included there just so that it's easy to find. The complex coding scenario got added to the original model, and this is when the clinician, someone who has a license like a physician, a PA, an ARNP, or APRN, they're actually working with the patient and not just a staff member or someone who's below that level. It does not need to be a specific licensed individual who's doing the traditional, the top 2 codes. It could be anyone trained adequately to do so. So in 2025, that reimbursement for the initial 20 minutes is about $60.49 from Medicare. Now that's kind of a national average, so it goes up and down depending on what part of the state you're in. But that's about average. In Medicaid, just to give you a comparator, as of 2025, February of 2025, the new regulations for the perfect care model, so to speak, that they have, is that all the health plans need to incorporate CDM programs. Now what that means though is each are going to incorporate them slightly differently. They may use the same codes, they may use slightly different codes. The reimbursement rates could be different. If you are in a particular region, and we're going to briefly mention that later, you may have 3, you may have 4, you may have 7 different Medicaid plans, and all of them could have slightly different rules and regulations about this. But the one thing I can tell you in talking with a recent conversation I had with my previous federally qualified health center, they went through not 1, not 2, and not even an internal program that they could make successful in accomplishing this. It's not that difficult, but even the people that they tried to contract with, it did not work out. They did not like the service that they received. They did not produce any benefits to their patients, and then it was kind of a waste of time, money, and effort. So they're still interested, but they can't find good people to do it. Now that was just one experience, but I can tell you that I've heard similar things from others, not having this direct conversation, but it's underutilized. The place that it's most often utilized is going to be with accountable care organizations, groups of physicians that have come together for quality improvement and shared savings. They will usually, the ACO will set up some kind of model to address these patients, because not only are they going to get a reimbursement for doing this, but they're going to raise their quality metrics as a large group and therefore get better shared savings in the end. So they're kind of double dipping is what their plan is for that. But nevertheless, if they're not being successful, if they can't broaden their reach wide enough, then certainly your MIH programs could fill in for them or be the actual substitution that they need, the contracted service, to accomplish something like this. So that brings us back to what we have previously discussed at meetings like this, and that is community health integrated services. So this, however, is in-person interventions, and it is addressing social determinants of health that another clinician has identified as impacting a person's health outcomes. My patient who has congestive heart failure never has adequate, good food, and therefore their salt content from all these prepared meals are raising their swelling and causing high blood pressure, and we cannot control their congestive heart failure. I can't fix that in the office. I need someone to spend time with the patient to teach them how to eat for congestive heart failure or diabetes or high blood pressure. So that's one very simple example. But 60 minutes in person, there are additional billable minutes by 30 more minutes. Also, I, as a clinician, I get mixed answers about physician assistants, but definitely an APRN and a physician, they have to initiate it. It can't be from the community health worker, the MIH program. It has to come from someone who's managing that person's health care and then identifying through an assessment that a social determinant is negatively impacting their health. So then this becomes, that's the focus, is to address the social determinant and improve the patient's health outcome and hopefully lower the cost. So Z codes 55 through 65 of the ICD-10, these are the ones that identify, so example, Z55.0 is literacy and low-level literacy. My patient can never read their prescriptions. They don't understand what they need to do about their diabetes. They can't read a nutrition label. These are kind of things that would actually improve a patient's health. I know that congestive heart failure keeps coming up. That scale issue that was talked about, a clinician in my community, he actually ran one of those one time, and just having that intervention over and over again took 11% readmission rates down to 0.3% readmission rates. For everyone that got put into his CHF program with one nurse practitioner, every patient got a scale, more, attentiveness to life rather than just medicine. And it took 18 months before the first person was readmitted within 30 days of discharge from a CHF event. So these things do truly have an impact, and that's what makes you all so valuable to the healthcare ecosystem. So reimbursement, these are the codes, and I listed the clinician assessment for the next part when we talk about, like, do we have somebody that works with us who's the clinician, or do we contract with somebody who's the clinician? We're going to get into that way you might set yourself up. So there's an assessment that can be claimed, and then there's the 60 minutes, and then 20 additional minutes. There are codes for that as well. In 2025, the average Medicare reimbursement for the first 60 minutes is $79, and then for the subsequent 20 minutes is $49 on average. Now, Medicaid rules will vary by state, and in our particular state, it varies by the plan. So again, they're required, so you got to go through each individual Medicaid plan. So more information about Florida Medicaid. So in the state plan, they do pay, there is documentation in there about paying for community health workers. Now, up to this point, if you're doing something unique with a hospital who wants to pay you to do something, or if you're doing chronic disease management, or you're doing the health integrated services, it's not an absolute requirement that someone is a CHW. It is highly recommended for both effectiveness, for legal protection, and then also for the upcoming changes to legislation. So you're prepared for tomorrow. Additionally, you're going to have a much better qualified individual handling these situations, and I think your program will be much more successful. Medicaid does require actual certification with CHS, for CHWs through the state. So one of the things that I learned as an FQHC chief medical officer is everybody has their own set of rules, and that's very daunting and challenging. So when you set your program up, you want to be able to meet the needs of lots of different individuals, Medicare, the various Medicaids, commercial insurers, even private institutions that may have a need. The key is to do what you do really well and then sell that to everybody else. And then, but you just have to be able to fit into their mold enough for the reimbursement part. But the care part is just what you're going to keep doing and doing well the way you know to do it well. So for example, if you spent 30 minutes addressing, chronic disease, okay, fine, it took you 30 minutes, but your outcome was so darn good that everybody's willing to hire you to do that. And if you're working on social determinants, the way you may actually do it could be very different than the next person who's trying to sell it to an FQHC or a hospital system or a large primary care clinic. If you can prove your outcomes, if you can prove that you make a difference, then they're more than willing to work with you. And all healthcare is local. People love to work with local people. And I can tell you they would much rather work with the people who show up to their office when 911 is called to take care of their patients every day than some company that's outsourced to another country just to talk to people on the phone and go through these scripts that really aren't making a difference for people. So aside from any of the programs mentioned thus far, there is legislation and there is guidelines for CHWs to be reimbursed directly through Medicaid. And the idea is that they're providing health promotion and coaching about chronic disease. There's care coordination, connecting the members to other resources within the community. And then navigating the health system. It's so very complex, making sure that they've got transportation, making sure that they go to their follow-up care, that they're adhering to the medication and the treatment that's provided to them by the clinic that they go to. Now, they must operate under a licensed practitioner, either as directly employed by the same clinic or hospital, or contracted by a hospital, a clinic, an FQHC, a private practice, etc. So either of those are acceptable. And again, the premise here and the guideline behind it is that the system, whether it's CMS or whether it's Medicaid at the state level, they want a clinician-level individual managing the system. And so they want that to initiate and that things fall incident to them being evaluated, assessed, and treated by a clinician. Because on the flip side, you do all the wonderful work you do, you report it back to a clinician like myself, and then I take that and I keep working with it. So I can make better adjustments to the patient's medicines. I can reduce the medicines that they no longer need because you guys have done a great job at changing their diet or changing their behavior. And so I still need to be a part of the plan as a physician who's managing the success that you all create on behalf of my patient. So when it comes to Medicaid, again, here are some of the codes that are specifically directed not within these other siloed billing reimbursement models, but directly related to the work that a CHW might do. Down the bottom is where all that information actually came from, the PDF that's available. So if you snap some pictures, and I'm sure we'll make that available to everybody after the conference. Everybody know that our regions have changed in Medicaid? I kind of recently learned this myself. So in 2022, they decided we were going to consolidate a little bit. It went into effect 2025. So we no longer have regions 1 through 11 for Medicaid. We now have regions A through I. And so the big change happened in the north half of the state. Just to go back, notice that region 3 and 4 have now consolidated. And then the entire panhandle is now region A. So if you're in one of those regions, just know that they got a lot bigger. All the other are the same. Now, this plays a role because the procurement for plans, Medicaid plans, is by region. So this is the map that tells you which region you're in and which health plans have achieved procurement, and they are actually operating in those regions providing Medicaid managed care services. So if you're interested in providing direct CHW work or a CDM or a CHI services that you want to get reimbursed, these are the Medicaid plans that you would have to talk to for your particular region. So this is available online as well. So how would you set yourselves up to financially make this work? And the way we thought about it in talking with you all, as well as the clinics, as well as the way the systems are designed, you either have an in-house clinician or you contract with a community clinician. So first, let's talk about the in-house clinician. So this is where your program would actually employ a physician, an APRN or PA within the CPMIH program. So the benefits is you now have full access, right? You can clinically evaluate and bill for those services directly. You can also do direct patient monitoring. You can create the incident to situation, and then you would simply follow up. Now, the challenges would be recruiting those individuals. I mean, they may love to work with you guys, or they may not love to work with you guys. And then the high costs. Those are high cost individuals, high salaries. There's the issue of the electronic medical record, and then the billing contract and billing software information. So having several conversations with you through the last year or so, your systems generally bill EMS billing. They're not directly equipped to manage E&M billing, evaluation and management codes. So usually, I've heard different stories. Some, they need a tweak, they need an update, they need the codes included, but then they would be able to submit them. Others say, no, they don't even do it at all. So when I showed you those other codes, those are CPT codes, and those are the same things that I would use for like when I see a patient in the office or when a hospital sees a patient. That's evaluation and management is like we're seeing and evaluating a person, and the CPT codes are procedural. You guys even have EMS codes, which are in a whole separate bucket. So that is another cost. If you're going to do the billing yourself, you may have to incur that cost of upgrading your billing operations in order to accommodate that. There's likely to be some training involved as well of the staff that are even doing the billing, because now it's a whole nother set of rules. On the flip side, if you're just going to run your service and contract with a community physician or a community clinic, they are going to be doing the billing for you, and then you're going to have to negotiate a shared reimbursement. So for example, the CDM programs traditionally ran about a 50-50 split. So we'll go do that 20 minutes of work, and the clinic will get 50% of that to actually submit and do all the billing. In this case, we've argued, and we have yet to see it actually happen or so, maybe some of you have some examples, but in terms of the CHI, where you're spending 60 minutes in person, I personally, and I'm even speaking as a clinician, feel like you all should take the larger share of that because you're doing a much more significant work. So maybe a 70-30 split is what I would argue as a starting point to see if you could make that contract stick 70% in your favor. Now, one advantage to that is obviously lower upfront costs. There's the broader patient recruitment. It's not just the people that you are going to see and then initiate care with. You could actually contract with all 3 FQHCs in your community. You could contract with a variety of different, primary care clinics, even an ACO in your area, so you could reach out and let them do all the finding of the patients, and then you would do all the management care of it. So that's an opportunity if you're not having to find all of those patients directly yourself. Also, the simpler documentation. You wouldn't necessarily have to have a compliant EMR in order to do all of the billing appropriately, because your documentation needs would just be enough to give back to the clinician to say, this is what we've done, this is what we've succeeded at. So there's a little bit less work on your part there. Obviously, it's more work recruiting partners, negotiating contracts, and then financially, it's less money. Now, you put less money up front, so you probably have to make it up in numbers in the end. That may not be a bad thing, that may be a good thing. That's what you all have to decide. So in choosing the right model, what are your resources? And what kind of goals do you have with the particular programs that you think you can offer in your given community? And do you have access to clinicians that you would be able to bring in-house? Or do you have access to clinicians in your community that you kind of already have a few relationships with and like, hey, can we do this specifically with you? Or would you consider expanding what we've already done and consider doing this? Would that benefit your patients? Because it certainly would benefit our program. And then, are you equipped to handle the in-house billing and EMR? We've kind of mentioned that. The takeaway is you want to select the model that best fits your capacity, but then also meets the needs for the program that you're trying to meet in your community. One of the things that we have learned along the way is there's plenty of grants that we could have gone after, but if it didn't meet our mission, it was a waste of our time, energy, effort, and it was miserable. But when we found the things that fit with where we wanted to go, then we've had success like you all have seen and heard about today and in the previous times that you have worked with us and the things that we have accomplished at CommHIT. So that's a lesson that I want to reiterate to you all. And when you're trying to go after programs like this and what your opportunities are, stick to your mission and then make it work. And we are more than happy to keep working with you, to keep doing the research, to try and figure out the ways that it can be more advantageous, how to navigate some of this. I'm very familiar with the clinician side of stuff. You guys are very familiar, and you're doing a wonderful job educating me on the EMS side of things, and I deeply appreciate it. I'm growing a lot, but it is a different world, and we're learning how that we may be able to bring those worlds together for the betterment of our communities and our patients. So we have resources on our website. We obviously have the CHW Training resources. That's what Kendra's going to talk more about next. We also have some sample contracts that we've already kind of put together that you have a starting place for, and I think some of you have even used these to begin negotiating in some of your communities. So, and we're continuing to build out more. We're actually in the process of reviewing some of the resources that we've developed in the CHW training that is directly related to the CHI services, the implementation, as well as those codes that we might actually run across, like homelessness, living alone, struggle with food or transportation, so that the CHW training is actually going to be about these kind of programs, so that at least we're introducing the CHWs to things that they're likely to hit the ground running with. So that's the kind of stuff that we're in the process of developing, and we should have completed fairly soon. And with that, I think I can turn it over to Kendra, and then after we'll take any questions that you guys have.
Thank you, Dr. Willis. I think a couple of those items that he's talking about on here, I know some of you have gotten to those, but those are password protected. I'll make sure that I send those out to the group when we send the slides. I do want to recognize Dixie County over here in the back, and the reason why is because they were the first in the state to do the community health integrated services in their area for their MIH program. And I think you guys did a 60-40 split, correct, with the physician that you're working with? Okay. Awesome. Yeah, right? Yeah, it's not a lot. I know you guys don't have a hospital, and you don't even have a lot of providers, but you know, certainly to be working in that direction, we're hoping that we could build it up from there. But if you do have some questions about it, certainly they have it operational right now, and you know, they can answer some of those questions. Chris, can you go to my slides, please? Thank you. I'm going to go fast because we're at time right now. All right, so I think David actually covered why you should get your CHW credentialing already. It's because there are Medicaid monies that are available for community health workers, and there's going to be more monies like that. So at CommHIT, what we like to do is make sure that we're hitting whatever the gold standard is and making that easy enough for you to get to that gold standard. That way, if there's anything that comes out, you're already prepared for that. You don't want to be trying to get a CHW credential because some Medicaid funds just came out that requires that. And you're going, wow, I should have done that when CommHIT had the grant and I could have gotten that free. But it's not only about the payments, but having the CHW, it allows you to take better care of the patients in your community.
So the way to get to that CHW credential, I would say the best way right now is to work through CommHIT, because we have this grant. It does sunset in 2 months, but if you send me your people right now, I can get them through. Palm Beach County, I think actually Lauren just left, but she sent me 15 people that we signed up within a few days, and they're already well on their way and finishing up some of their trainings. So here are the steps to get to that. So the first thing you need to do is make sure that you send all of the names of your employees that you want to get that community health worker training and credential to Andy Post. His email is there, and we'll be giving out all of these slides. Andy's going to help those folks enroll into our grant, because we have to have them enrolled so we can document where our efforts and our funding are going for the certain individuals going through the CHW program. And then Kevin Salser, he then adds them to CommHIT's learning management system. We have a tech-based community health worker core training that is Florida Certification Board approved. We did make that about 40% technical, so it has telehealth, it has broadband, it has patient portals, and some digital security as well as digital literacy for those in your communities. And the reason why we did that is because of when the social distancing happened during COVID. And people who didn't know how to use the computer, or they were scared that they were going to get hacked because they did something, a lot of them weren't able to get to care. So we don't want something like that to happen again. We want to make sure that everybody's connected as much as possible using technology and also using that human in-person touch. But Kevin will add people to the system within 2 or 3 days of receiving that information from Andy. So the trainee then goes through our learning management system. It's all asynchronous online, so they can do it when it's convenient for them to do. So it's at their own pace, but it is 20 hours of work that they're supposed to do on that learning management system, or LMS. Once they complete, then they go back to Kevin and they say, hey, I'm all set, I completed. He'll review that, make sure that they did actually complete, and then he's going to provide them the certificate from CommHIT that they'll need for their application to the Florida Certification Board for the credential. And CommHIT also provides technical assistance with the Florida Certification Board submission. So there are 10 hours of electives that are also required with this. And typically what we find are the trainees that are coming from fire rescue or just EMS that are going to get their credential, they already have that elective training done. It's just a matter of finding what finding what courses they took actually meet those requirements. So we help either find those, and if they don't have enough hours with the electives, then there are courses that we offer that they could quickly take on the LMS. We cover the cost of all the training and all the application costs. We also cover the cost of the background check. A level 2 background check is required. Once that trainee gets approved, they're approved to take the exam. Then we send them a practice exam that we have them take. We also have additional training materials of items that they are going to need to pass that particular exam that are over and above what we train them on with the community health worker core training and the electives. So they study those, they take the exam. A passing grade is 70%. The majority of our trainees have been getting over 90% on these. So they're passing with flying colors, becoming CCHWs, where they can put that credential after their name. So if you want to get started with the CCHW, or if you are one of the people who they're already doing the CCHW with CommHIT, but you fell off the wagon, just know that our grant that we're doing most of the CHW training on, that sunsets in July. So we're trying to get you to kind of hurry up. Send your people in that you want them to get trained. Finish up if you can. We don't have to have you finish by the time that grant ends, but we'd like to get you as far along as we possibly can with the grant. We'd at least like to be able to use those funds to reimburse what we're doing. We have an additional grant now called Good Jobs for All, CHWJFA, and that one's available through July 2028. That particular one is mostly focused on apprenticeship and pre-apprenticeship. The CHW, we can include that under the pre-apprenticeship piece because it does apply to some of our apprenticeships, but there's a lot less funds that are there for that type of training. It's more for people who are going to take the plunge and do the whole apprenticeship program. So that particular grant, it comes from the U.S. Department of Labor. It's a $4 million grant. The reach of it is nationwide. Of course, since we are headquartered here in Florida and we've done a lot of work here, we want to make sure that we are taking care of our Florida entities, especially fire rescue and nursing. That grant, we really focused it on public safety. Public safety to us is fire rescue. It's our first responders. It's nursing. It's cybersecurity and technology. And it's also utilities, because you know what happens when hurricanes hit and the utilities go out. That's a public safety issue to us. So I'm going to go with a fire rescue example for this GJFA grant. So as I mentioned earlier, we did get our Florida Department of Education to approve our career lattice in November of 2024. And Town of Jupiter is going to be our first fire rescue department using that grant. So we look at them kind of like guinea pigs, but we have done apprenticeship before, so we don't really see them as guinea pigs. I think they see themselves as guinea pigs for everyone in this room right now, though. So we wanted to make sure that there was career progression that's also built into that. That's why it's called a career lattice. So somebody can go from no training at all or experience, they get their EMT license and they get their firefighter level 2. If they do that by the end of year 1, they have a mentor, they're able to check the box on things that we consider job competencies that go by national standards, then they complete that apprenticeship program for EMT firefighter level 2. They can then go into the second apprenticeship program for paramedic, and that also takes them through community paramedic, and they get the CHW training along the way there. And the way that we set that up with the state is that they can do that in 1 year as well. Now, if somebody were going part-time, if you have an incumbent worker that they've already done EMT, but you want to just get them in paramedic, we can work out that as well. So, you just let us know what your needs are. This is flexible enough for your needs. There are some agencies in Florida that aren't fire-based. They're EMS agencies, and there's ways that we can also remove the firefighter level 2 requirement that's in here, so it fits those agencies. So really it's about just getting in touch with us so we understand what your needs are, and we're able to modify these standards to the way that you need to have them modified and push that through. So the things that make apprenticeship hard, those are the things that CommHIT focuses on for you. We want you to be able to build your workforce the way that you need your workforce for the community. We don't want you to have to worry about knowing all of the apprenticeship policies. Yes, you do need to know them. We will share the guidebook with you. We will make sure that you understand the pieces. But in terms of the technical parts where we're searching through things, what can we do, what can't we do, that's for CommHIT, and also our administrative entity, PCG, helps us with that. Mike Lawrence, he's in the back, he's going to be speaking tomorrow also. He's also a very wonderful resource for us. Florida Department of Education, Ann Everly, Melissa Byers, Joy Jamerson. We have a whole group of people that we work with, and all of us are experienced in apprenticeship programs as well as different types of job occupations. I've been doing fire rescue work since, as Chief Donato said, he met me 15 years ago. So I used to be the organizational lead for the North Central Florida Trauma Agency. I started the North Central Florida Healthcare Coalition for them. I brought the Florida Association of Rural EMS Providers back after they were dissolved for many, many years. So I've worked in fire rescue for many years. So you are very dear to my heart, and I want to make sure that your workforce is at the standard that it needs to be, and apprenticeship programs are a way that we can build that'll be enduring for you. We also want to make sure that CommHIT is taking care of any type of compliance or extensive documentation. Now, we do need to have a contact with your HR, and we need to have a contact with the person that's supervising your apprentice that's coming through. But we only need to talk to that contact about once a quarter to get information, and we streamline what we're asking for from you. So we want to make this as easy on you as possible. We also try to help with finding you funding for wages and funding for the training. So you heard from Kim Teshvat earlier this morning where she's talking about some of that. Also, Chief Donato was talking about some legislation that may be coming through that will help with that as well. You also heard from Melissa Byers, who was talking about some career source funding also. So there's different ways that we can work things. It is case-by-case basis, but we definitely want to use all of the arrows in the quiver that we possibly can for each and every one of your agencies. So you can use that career lattice for incumbent workers, new employees. The thing about apprenticeship programs is it's not an internship. It's not somebody there just observing. It's an employee. They may not be trained all the way, but I know that you guys have EMT training programs, a lot of you that are already, already set up in your agency. So we want to make sure that we're building those out in a way to where the Department of Education is recognizing that. One of the little kind of catches about apprenticeship programs, and again, this is something that you already do, when your apprentice reaches licensure for EMT and firefighter level 2, they do need a bump in pay. The same needs to happen for paramedic, but I know that you guys already do that already. So there's a way that we can build these programs that it's already going to fit what you're doing. And then to get you started with apprenticeship, we want you to have a meeting with CommHIT. We want to discuss with you what it is that you need, so we make sure that we're responsive to your needs, so we're not telling you what to do and you're like, this is not going to work for us. We want to make sure that whatever we're telling you is going to work for you. You'll then sign an MOU to be a grant partner with CommHIT for the apprenticeship grant, the Good Jobs for All, the same way many of you did for the C3W Plus grant for the MIH program development, and the same as you did for the RRCC program. A lot of you got healthcare occupations, your training paid for, including EMT and paramedic, over COVID using our other U.S. Department of Labor grant that is already sunsetted. Then you need to sign the government required employer agreement. I said government required because right now for the fire rescue, it will be Florida Department of Education required, but depending on what apprenticeships we build out, it may be a national one, so it might be a different entity. You also need to provide your pay schedule and where you want your apprentices to receive training, and that's not because we need to know, it's because it's a requirement by the Florida Department of Education. We have to submit that information to them. So we only ask you the information that we need to know at the minimum that's part of the rules for apprenticeship program. The rest is up to you because it's your fire rescue, it's your EMS agency, and we want to make sure that it's run the way that you want it to. Also, if you can identify apprentices then on step 5 and send their contact information to Andy, we get them enrolled into the grant as well. And then you provide us with an HR and immediate supervisor contact so we can get quarterly metrics. And that is it for me today. I went over a few minutes. I'm very sorry. So any questions? Are you guys ready to get out of here? All right. Thank you so much, everyone. Thank you for coming today.